in the United States, we've long struggled with harm reduction, and actually I think that racial stereotypes have been a big barrier. Harm reduction hasn't been a major part of the national agenda until now. And so now that the racial image of who's dying and who's becoming affected is changing, now it's on the agenda. And for the first time, American policymakers are beginning to look to Canada and beginning to look to studies that have been done of harm reduction approaches. This morning I gave the example of Staten Island, which is a largely white, middle class to affluent borough of New York City. And in Staten Island, there is a comprehensive program by which the district attorney, the prosecutor there, if anyone is arrested on opioid possession charges, rather than pursuing sentencing, he's agreed to have them referred to treatment and be matched with a peer who's in recovery from opioid addiction. That is a 180-degree turnaround from the normal punitive response that we've had to drug possession in the US. Now I say selective decriminalization because that's happening in Staten Island, but it's not happening in the South Bronx, which is actually where the majority of overdoses are taking place at this point. It's a Black and Latino low-income area where rates of overdose are actually going up, and they're beginning to rival Staten Island's. We're not seeing that approach anywhere else actually in the New York City area. So, and this is being replicated throughout the United States in that it's predominantly white neighborhoods where law enforcement is changing and decriminalizing around opioids and a new emphasis on treatment. So I don't know that safe injection facilities are really on the minds, or at least on the lips, of federal legislators at this point. But the idea of harm reduction, even when it comes to buprenorphine maintenance, as a harm reduction measure, something that is going to lower overdose rates, that's an agenda that's been heavily pushed at the federal level. We're really now embracing access to buprenorphine. And the problem with it in terms of equity in the United States is that our healthcare system is so divided and stratified in terms of who has access to a regular doctor, who has access to someone who's certified to prescribe buprenorphine. That's where the rub lies. But on other levels, buprenorphine as a harm reduction measure is a big part of the national agenda. And that certainly relates to the identity of the people who are thought to be at highest risk right now. So the innovation with buprenorphine was getting federal law passed to enable primary care doctors to prescribe it for home use. Prior to that, the 1914 Harrison Act had prohibited private office doctors from treating opioid addiction with opioids. So that is a big innovation, and there's the promise there of increasing access to treatment for a lot of people. So in the US, we're investing a lot in the pharmaceutical, in buprenorphine, and we're not investing in the other infrastructure, social services, therapy, trauma-informed care. We know how complicated the histories are of people who are addicted and how many different tools have to be brought to bear to help them recover. So we're so focused on the pharmaceutical in a system where the pharmaceutical corporate lobby has incredible power when it comes to health policy, setting health policy and reimbursements, and where pharmaceuticals represent one of the major economic drivers in our economy. So it's lopsided. The emphasis is on the drug. And the problem is that we're not preparing primary care doctors with skills, with referrals, with other kinds of resources, therapies, social services, people who can help make those linkages that would lead to long-term success in treatment.